welcome to the deep dive. Today we're tackling, something pretty much everyone's experienced or seen.
That's sudden ankle roll.
Exactly. Ankle sprains. We're doing a deep dive, aiming to give you a really solid understanding. Useful day-to-day, but especially handy if you're prepping for exams like the MSRA.
We've sifted through quite a bit of material to, put together a comprehensive overview.
Yeah, the mission today is basically to extract those key facts about ankle sprains, make it easy to grasp, easy to remember.
Right. From the basic anatomy, what goes wrong, how we fix it, the whole journey, trying to make it stick.
Okay, let's kick things off. Ankle sprain. What are we actually talking about at its core?
Fundamentally, it's damage to ligaments. Those are the tough, sort of stretchy bands that hold your ankle bones together.
Like little stabilizers?
Precisely. And a sprain happens when they get stretched too far or sometimes even torn, usually from a twist or a roll.
Okay, so which bones are these ligaments connecting? What's the basic structure down there?
You're mainly looking at the bottom ends of the tibia and the fibula, your shin bones, and the top of the talus bone.
The talus sits sort of above the heel bone.
That's the one. Think of the tibia and fibula forming a kind of socket or bracket around that talus bone.
Got it. Bones, framework, ligaments, connectors. So what are the key ligament groups we need to know?
Okay, there are essentially three main players. First, there's the syndesmosis.
Syndesmosis.
Right. These ligaments bind the tibia and fibula together, but a bit higher up than the main ankle joint itself.
Oh, okay.
You'll hear about the AITFL, PITFL, the interosseous ligament, the membrane.
Right.
When these get injured, that's what we often call a high ankle sprain.
Key ankle sprain. Because it's higher up. Okay. Makes sense.
Exactly. Then second, you have the lateral collateral ligament.
Lateral meaning?
On the outside of the ankle, these connect the fibula, that outer shin bone, to the talus and the calcaneus, which is your heel bone.
Right.
The main one here, the one that gets injured most often, is the ATFL, the anterior talofibular ligament.
ATFL.
Good. Yeah. Then you've also got the PTFL and the calcaneofibular ligament in that group. Injuries here are your classic low ankle sprains.
Low and lateral.
Right.
And the most common type, you said.
By far, yeah. That inward roll usually gets these ones.
Okay, and the third group?
That's the deltoid ligament. It's on the medial side, the inside of your ankle.
Deltoid, like the muscle.
Named similarly, yeah, because it's kind of triangular shaped. It's a really strong ligament connecting the tibia to the talus and other bones on the inside.
Stronger, so injured less often.
Generally, yes. Eversion injuries rolling outwards are less common, and this ligament is pretty robust.
Okay, so bones, ligaments. What movements does this whole structure actually allow? It's not just up and down, is it?
Oh, definitely not. Your ankle's pretty clever. You've got dorsiflexion pointing toes up.
Towards the shin.
Right. And plantar flexion pointing toes down.
Pushing off.
Exactly. But then you also have inversion, turning the sole of your foot inwards.
The con sprain move.
Usually, yeah. And eversion, turning the sole outwards. Plus, it's constantly adapting to bear your body weight during pretty much any activity.
It's a complex bit of kit. What are the actual joint names involved?
Well, the main up and down movement happens at the tibiotalar joint. That's between the tibia, fibula, and the talus.
The true ankle joint.
You could say that, yeah. And then just below it, you have the subtalar joint between the talus and the calcaneus, the heel bone.
And that's where the side-to-side tilting happens.
Primarily, yes. That inversion and eversion. And again, it's those ligaments, syndesmosis, lateral collaterals, deltoid that provide the stability needed for all this. They connect tibia, fibula, talus, calcaneus.
Keeping it all in check. Okay, so we understand the structure. How did these sprains actually happen? What's the usual story?
It almost always comes down to excessive inversion or aversion. Like we said, that inward roll, excessive inversion is the big one.
Why is that one so common?
It just seems to be biomechanically easier for the ankle to roll inwards too far. That puts a sudden, massive stress on those lateral ligaments, especially the ATFL.
And the outward roll, eversion.
Less common, but it happens. That stresses the medial deltoid ligament.
So it's that moment your ankle just gives way. When does this typically occur?
Very often in sports, Anything involving running, jumping, quick changes of direction. Think basketball, soccer, netball.
Uneven surfaces too, I guess.
Absolutely. Stepping awkwardly off a curb, walking on rocky ground, landing funny. Any situation that forces the ankle into an unnatural position suddenly.
Makes sense. Are some people just sort of built more prone to these? What are the risk factors?
Definitely. Participating in those high-risk sports is a big one. But a really significant factor is having had a previous ankle sprain.
Once sprained, always.
Well, not always, but the risk goes up. The ligaments might be a bit weaker, or your proprioception, your joint position sense might be slightly off.
Like you don't quite trust it anymore.
Something like that, yeah. Or it's just inherently less stable.
Anything else?
Yeah, inadequate warm-up or stretching before activity can be a factor. Makes the tissues less pliable.
Right.
And footwear. Wearing shoes without proper support, especially for the activity you're doing, can definitely increase your risk.
Okay, so the ankle rolls, ligaments get stretched or torn. What's happening at the tissue level? The pathophysiology.
So you get actual physical damage to the collagen fibers within the ligament. Like we keep saying, usually it's those lateral ones, ATFL, maybe the calcaneofibular ligament too.
And the body's reaction.
Immediate inflammation, blood vessels dilate, fluid rushes in. That's your swelling. Chemicals are released that cause pain. You might see redness, feel heat.
The inflammatory cascade.
Exactly. It's the body trying to heal, but it causes those initial symptoms. Longer term, if the damage is bad or it doesn't heal right, you can end up with joint instability.
That feeling of it giving way again.
Precisely. And reduced function overall.
Okay, so someone comes in, painful, swollen ankle, looks like a sprain. But what else could it be? What are the key differential diagnoses?
Super important question. You have to consider fractures. Ankle fractures are common, especially if the pain is severe right away or they absolutely cannot put weight on it.
Any specific fractures we should keep in mind, things that get missed?
Yeah, definitely think about the proximal fibula way up near the knee, surprisingly. Base of the fifth metatarsal on the foot. Talar fractures like the dome or the lateral process, the snowboarder's fracture. Tibial clefon fractures, too.
Wow. Okay, so rule out fracture first. What else mimics a sprain?
Syndesmosis injuries, those high ankle sprains, can present similarly but often have pain higher up or with specific movements like external rotation.
Right.
Peroneal tendon injuries, those tendons run down the outside of the ankle, can cause lateral ankle pain too. Sometimes they even sublux or dislocate.
Tendon issues. Any others?
You could have Achilles tendon problems presenting with posterior ankle pain, joint issues like gout or osteochondritis dissecans, other tendon issues like tibialis posterior, even stress fractures if the pain came on more gradually.
So a good history and examination are key to narrowing it down.
Absolutely. And that leads us to things like the Ottawa rules.
Before we get to investigations, just quickly, how common are ankle sprains? What's the epidemiology?
Oh, they're incredibly common. One of the most frequent musculoskeletal injuries worldwide.
Really?
Yeah, huge numbers turn up in A&E, GP clinics, physio departments, especially common in active people.
Any specific groups?
Definitely younger people, adolescents, young adults, partly because they tend to be more active in sports. And athletes, obviously, have a much higher incidence.
Okay, so someone's rolled their ankle. What are the classic clinical features we're looking for?
Well, pain is usually the first thing, then swelling, tenderness when you press on the injured ligaments. Bruising often develops, maybe not immediately, but over the next day or so.
And difficulty walking.
Yes, difficulty bearing weight is a big one. How much difficulty often relates to the severity of the sprain.
Right. You mentioned severity grades earlier.
Yeah, we usually grade them IIT or 3.
Can you quickly break those down?
Sure. Grade hurt is mild. Just stretching or it's tiny micro tears in the ligament. Minimal swelling, maybe slight bruising. They can usually walk, though it might be a bit painful.
Okay, grade 2.
Moderate. A partial tear of the ligament. You'll see more obvious swelling and bruising. Walking is definitely painful, more difficult.
And grade 3.
That's severe. A complete tear or rupture of the ligament. Lots of swelling. Significant bruising is common. Very painful, and usually they can't put weight on it at all, or it feels very unstable if they try.
Got it. And remember, most are those lateral low sprains from inversion. High sprains are less common, but often worse.
Generally, yes. They tend to be more painful and take longer to fully recover.
Okay, assessment time. Someone comes in. What's the approach?
Standard initial assessment. First, A, B, C, D, E. Make sure they're stable overall. Then focus on the ankle. Look for obvious deformity. Does it look out of place?
Suggesting a fracture or dislocation?
Exactly. Check the neurovascular status immediately. Pulses in the foot, sensation, can they move their toes? Needs to be done early. If there's a fracture dislocation, it needs reducing quickly.
Okay, assuming no immediate life or limb threat, then what?
History. How did it happen? Mechanism is crucial. Where does it hurt most? Could they walk on it right after it happened? Did it swell up instantly?
Why is immediate swelling significant?
It often suggests bleeding inside the joint, a hemarthrosis, which usually points towards a more severe injury, like a ligament rupture or interarticular fracture.
Okay, history done. Then the physical exam.
Yep. Look closely. Observe them walking if they can manage it. Note any deformity, swelling pattern, bruising location, any skin breaks or wounds. Then gently palpate, feel along the bones, the ligaments. Feeling for tenderness specifically over the ligaments or bony landmarks, any crepitus, that crunchy feeling that might suggest a fracture, and recheck that neurovascular status.
Are there specific tests we can do if they tolerate it?
Yes, if pain allows. Thompson's test for the Achilles tendon squeeze the calf. Foot should plantar flex.
Right.
Anterior drawer test for the ATFL, stabilize the lower leg, pull the heel forward. Too much movement suggests the tear.
Okay.
Talar tilt test for the calcaneofibular ligament, gently invert or avert the heel, feeling for excessive tilting or gapping. And specific tests for the syndesmosis, like the squeeze test, squeezing the tibia and fibula together higher up the calf, or the external rotation stress test. These might provoke pain if the high ligaments are injured.
So those grades, again, just to nail it down, grade 1.
Mild, stretch, micro tear, minimal swelling, bruising, can weight bear, painful but possible.
Yeah.
Localized tenderness.
Grade 2.
Moderate, partial tear, more swelling, bruising, painful, weight bearing, difficult. More widespread tenderness.
Grade 3.
Severe, complete tear, significant swelling, bruising, usually unable to weight bear due to pain and instability. Widespread tenderness, feels unstable.
Okay, clear. Now, investigations. You mentioned the Ottawa rules for x-rays?
Yes, they're really key for deciding who needs an x-ray to rule out a fracture. Remember, most ankle injuries aren't fractures, maybe only 15% or so.
So they help avoid unnecessary radiation and cost. What are the rules for an ankle x-ray?
Okay, you need an ankle x-ray series if there's pain in the malleolar zone around the bony ankle bumps, A and D, one or more of these, bone tenderness along the back edge, or tip of the medial malleolus.
Inside bump.
Right, or bone tenderness along the back edge or tip of the lateral malleolus.
Outside bump.
Correct. Or they are unable to bear weight for 4 steps both immediately after the injury and when you're assessing them in clinic or A&E.
4 steps.
Got it.
What about foot x-rays? Different criteria.
Yes, separate criteria. You need foot x-rays if there's pain in the midfoot zone, A and D, either bone tenderness at the base of the 5th metatarsal.
Bony bed on the outside of the foot.
Yep. Or bone tenderness over the navicular bone.
Inside arch area.
That's one. Or, again, that inability to bear weight for 4 steps, both immediately and at assessment.
Okay, so Ottawa rules are crucial for fracture exclusion. What about other imaging, like MRI?
MRI isn't usually needed right away for a typical sprain. It's more useful later if things aren't getting better as expected.
We're looking at.
It gives great detail of the soft tissues, ligaments, tendons. So if you suspect a complex ligament injury, a tear that hasn't shown up, associated tendon damage, or maybe cartilage damage, MRI can be very helpful, especially for persistent pain or instability.
Right. And just quickly differentiating against sprain versus, say, a muscle strain near the ankle.
With a sprain, the main findings are tenderness over ligaments, joint swelling, maybe instability tests are positive. A muscle strain usually has tenderness over the muscle belly or its tendon. And pain is worse when you use or stretch that specific muscle. Less likely to have that significant joint swelling or instability you see with ligament tears.
Okay, and sprains are lateral, graded a 3 usually, or syndesmotic, which is different.
Exactly. Lateral is most common. Syndesmotic involves different ligaments, different mechanism, often needs more careful management, and takes longer.
All right, let's talk management. We've diagnosed an ankle sprain. What's the immediate plan?
First 72 hours or so, it's all about the PRICE protocol.
Price. Okay. B.
Protection. Protect the ankle from further injury, maybe a supportive bandage, brace, or even crutches if needed. Rest. Avoid activities that cause pain. Doesn't necessarily mean total non-weight bearing for mild sprains, but listen to your body. Maybe 48, 72 hours of relative rest.
Aye.
Ice. Apply ice packs wrapped in a towel, never directly on skin, for maybe 15-20 minutes every 2-3 hours while awake. Helps with pain and swelling. Compression. A simple elastic bandage applied firmly but not too tight can help control swelling and provide some support. Start from the toes and wrap upwards.
And E.
Elevation. Keep the ankle raised above the level of your heart as much as possible, especially in the first couple of days. Uses gravity to help reduce swelling.
Grace. Got it. Anything we should actively avoid initially?
Yes, remember harm.
Harm.
Heat. Avoid hot baths, heat packs initially as they can increase swelling. Alcohol can delay healing and increase swelling. Running or any activity that aggravates the injury. Deep massage right on the injured area in the first few days might increase bleeding or swelling.
Avoid harm. Good mnemonic. What else in terms of early treatment?
Pain relief is important. Simple analgesia like paracetamol. NSAIDs like ibuprofen can also help with pain and inflammation, but there's some debate about their effect on tissue healing, so maybe use them selectively for significant pain.
Mm-hmm.
For simple, mild sprains, gentle range of motion exercises can start fairly early as pain allows. More severe sprains might need a period of immobilization in a boot or brace for stability.
And those high ankle sprains?
Syndesmotic sprains often need more protection, sometimes a walking boot, potentially even a cast, and maybe a period of non-weight bearing depending on severity and stability.
When would surgery come into the picture?
It's not common for acute sprains. Usually reserved for severe grade 3 tiers with significant instability, especially in high-level athletes, or for chronic instability that hasn't responded to conservative treatment like physio.
Speaking of physio, how important is that?
Oh, absolutely essential.
Yeah.
Proper rehabilitation with a physiotherapist is key to a good outcome.
What does physio involve?
It's a progressive program. Starts with regaining range of motion, then moves on to strengthening the muscles around the ankle, improving proprioception, that's your balance and joint position sense.
Wobble board stuff.
Often, yeah. Balance exercises are crucial. And finally, sport-specific drills to get you back to your activities safely.
How long before returning to sport?
It varies hugely depending on the grade of sprain in the sport. Could be a couple of weeks for a mild one, but often more like 4 or 6 weeks or even longer for moderate to severe sprains, especially high ones. Rushing back is a big risk factor for re-injury.
Makes sense.
Yeah.
What about long-term rehab and prevention?
Completing the full rehab program is vital. Don't stop just because the pain is gone. For prevention, especially if you've had sprains before or play high-risk sports, continuing balance and strengthening exercises is good. Some athletes benefit from wearing an ankle brace or taping during sport.
And for that chronic instability?
If the ankle keeps giving way despite good rehab, then ongoing bracing or potentially surgery to repair or reconstruct the ligaments might be needed. About 30% of people do have some persistent symptoms, so it's not always straightforward.
Any other prevention tips?
Good footwear is always important. Maybe consider ankle supportive boots if you're hiking on rough terrain, maintaining good ankle strength and balance generally.
Okay. So overall, what's the prognosis? What's the outlook?
Generally pretty good, actually. Most people recover well from an ankle sprain within weeks to a few months, especially if they get good advice and do their rehab.
But there's a...
But if it's not managed well, or if someone has recurrent sprains, they can develop that chronic instability we talked about, which increases the risk of further sprains and potentially long-term problems like arthritis.
Right. So what are the main complications we might see?
Chronic ankle instability is the big one. Persistent pain or swelling that just doesn't settle, limited range of motion, stiffness, muscle weakness around the ankle, and down the line, post-traumatic osteoarthritis is a risk, especially after severe or repeated injuries.
So the take-home is really manage it properly from the start.
Exactly. Good acute care with price, followed by thorough physiotherapy focusing on movement, strength, and balance. That gives you the best chance of avoiding those long-term issues.
Okay. Fantastic overview. Covered a lot there. Any final thoughts or key messages for our listeners?
I think the main thing is, don't underestimate an ankle sprain. While common, proper assessment to rule out serious stuff like fractures is crucial. Follow the early advice price, avoid harm, and most importantly, commit to the rehabilitation. It's tempting to stop when the pain eases, but completing the strength and balance work is what really helps prevent it happening again and avoids those chronic problems.
Solid advice. Taking the time to recover properly pays off in the long run for staying active.
Absolutely.
Brilliant. And for anyone revising this topic or any other medical conditions or exams like the MSRA, definitely check out passthemsr.com.
And there's also freemsra.com for loads of free resources too.
Great stuff. Thanks so much for joining us on this deep dive into ankle sprains.